Good morning, everybody. We will talk today about aortoostial lesion with focus on floating wire technique. Let's ask ourselves why Emmanuel Brilakis consider ostial lesions as a complex lesion. First of all, what are the ostial lesions? It is ostial RCA or ostial left main or ostial lima or ostial saphenous venous graft. What is the problem in ostial lesion? There is a pressure dampening upon engagement. And what is the problem of pressure dampening? It leads to ischemia and hemodynamic compromise, of course. And of course, don't inject during pressure dampening because you can induce a dissection. Of course, traditional causes of pressure dampening should be excluded, such as intracatheter thrombus or debris, kinking in the catheter, non-coaxial alignment, or malfunction of the transducer. So if there is an ostial lesion, for example in the RCA, there is a pressure dampening on guide engagement, and if you disengage the guiding catheter, no pressure dampening. So what are the other challenges with aortoostial lesions? Other than the pressure dampening and subsequent ischemia, you may miss the ostium. Secondly, on the other hand, the stent may be excessive overhang into the aorta. Of course, this will lead to many problems, such as inability to re-engage again. So it is really complex. Let's look to this case from the American Board Review. There is significant ostial lesion of the RCA, stenting, but unfortunately, they missed the ostium. And this is confirmed by Ivas, by the way. That's why he had to insert another stent to really cover the ostium, and this is the final image. So, knowing where is the real ostium is very important. First of all, if you find ostial lesion, inject nitroglycerin and obtain the view that will show you the ostium better. For example, if it is ostial RCA, low caudal. If it is ostial left main, low cranial. There is some maneuvers to prevent pressure dampening. For example, using a small guide catheter, and of course avoid deep guide engagement, or using guide catheters with side holes, like this. But bear in mind that it shouldn't be used in unprotected left main because it will give you false sense of security. However, the pressure isn't really the intracoronary pressure. Second problem, you need to inject a lot of contrast to see the coronary artery clear. Another solution to use Ostial Pro device. Let's see this short animation. Engage the RCA, then wiring, then introduce your stent, then disengage and insert your Ostial Pro device. It will prevent the guiding catheter from engagement. Secondly, it will demark the ostium of the RCA and then deploy your stent and ostial flaring. What other measures to prevent pressure dampening? using a small guide catheter extension to engage the coronary artery and back out the guide catheter. Or finally, place a floating wire in the aorta to keep the guide catheter out of the coronary artery. Here are some tips. First of all, before engagement, please introduce your guide wire inside the guiding catheter near the tip of the guiding catheter. So you will engage and introduce your wire inside the coronary artery, then disengage, hit and run. So the period of pressure dampening is very short. If you didn't use the floating wire technique, for example, if we do a PCI to RCA, you can intermittently disengage the guide catheter to make the period of pressure dampening and ischemia as short as possible. And disengagement, you torque the guide into non-coaxial position. For example, if you engaged by clockwise rotation, please disengage by anti-clockwise rotation. However, if you pull back the guide catheter, all the system may be out of the coronary. So don't do this, please. So, what is the floating wire technique? Is it really succeeded to make a difference? Yes. Floating wire technique compared to single wire technique was better in angina frequency and need for revascularization after 1 year of follow-up. This is a case of ostial RCA. First step, nitroglycerin. Still the same, so it is really an RCA ostial lesion. There is a technique Emmanuel showed us, which is independent hand technique. The left hand manipulating the guiding catheter, for example, introducing or pulling back or rotate, while the right hand control the stent shaft or the balloon shaft. And here is the guide wire. Let's show you from another angle. This is the left hand controlling the guiding catheter, while the right hand controlling the material, the stent shaft, and the guide wire here between the little finger and ring finger. Let's show you. This is the guide wire, this is the shaft of the balloon, and this is the left hand manipulating the guiding catheter. So this is the traditional two-hand technique, and this is the independent hand technique. So this is the floating wire, and it will prevent the guiding catheter from engagement of the RCA and also demarcate where is the ostium. It's here. So you put your stent at the ostium and withdraw 1 to 2 millimeters to protrude in the aorta and start to deploy your stent. So you prevented the guiding catheter from engagement of the RCA, and also you could demarcate the site of the orifice of the RCA. Then pull back your guiding catheter and pull back your balloon to flare the ostium and make the struts in place. Pull back, then do the ostial flaring, and now you can see or you can imagine where is the ostium, and confirm by IVUS. Here we pull back the IVUS and we can see blood inside and blood in the water outside. So the ostium covered successfully. So in Aortoostial PCI, you can use the intermittent disengagement by clockwise and anti-clockwise rotation. However, floating wire is better actually because it prevents the guiding catheter from engagement of the coronary artery, so no pressure dampening, no ischemia, and also it will show you where is the true ostium of the RCA. Don't forget to post-dilate the ostium of the stent by the flaring we showed you a few seconds ago, and IVUS to confirm the ostial coverage if available. So floating wire technique is a quick and easy way. Don't forget that the ostium is often farther back than you think. It's very low risk of missing the ostium because you see or you demarcate the real position of the ostium and you know the location actually. And what about the other challenge, which is the overhanging in the aorta? You maintain forward pressure on the guiding against the ostium and don't afraid you will not engage because there is a floating wire preventing the guiding from engaging the coronary artery. So now you are close of the ostium and you can position your stent just 1 to 2 millimeter into the aorta, and now you avoided the hanging too much. Don't forget that ostial flare, the stent balloon inflated halfway in the stent and halfway in the aorta. What's about re-engagement? Deflate your balloon and advance the guiding catheter over the deflated balloon to be able to re-engage the vessel again. What's about ostial flash balloon? It is another way to flare the ostium by this ostial flash balloon. In our case, we followed the steps of Emanuel Birolakis, and fortunately we succeeded to cover the ostium. This is another case. A few years ago, a 69-year-old female presented to us with acute inferior ischemia complicated by complete heart block, and she was renally impaired. So we introduced temporary pacemaker as fast as we could, and we did the primary PCI using the floating wire technique, and fortunately we could cover the ostium without missing it and without overhanging, fortunately. And thank you